Okay, so first of all, I'm happy to be here, and we'll start on the rule of cytoreductive nephrectomy and there of target therapy. In general, we can say that despite the fact that metastatic kidney is going down on the percentage, still, if we look at the SEER data of the last decade, we can see that even in our days, about 1 out of every 6 patients will have metastatic disease. And definitely we need to have a precise role for those patients as well. Right now we have many options that we actually don't have a very good answer what is the right one. It can be either target therapy followed cytoreductive nephrectomy and metastatectomy, and cytoreductive nephrectomy followed by medical therapy. Which is the one to choose, we don't know yet for sure. We have 2 very important trials that were published more than 10 years ago, and that showed that if we add medical therapy at that time by the interferon alpha, we can see improvement in patients that are undergoing cytoreductive nephrectomy. This is the paper of Mikish from Lancet, and the other one from the New England show basically the same, with improved survival from 11 months out compared to 8 months in the combination therapy. The problem with those 2 trials, first, they have limited number of patients. We are talking about good performance status of patients. The metastasis was mainly lung. Pathology was completely for conventional type. The medical therapy was interferon, and we didn't use any risk, the author did not use any risk criteria to establish the data. So first of all, this group of patients is composed of 1/3 to half of the patients we are dealing, and most of us don't use any more interferon. So those papers are relevant regarding the concept, but not for the exact cohort they represent. So despite the fact of that's a conclusion from the European urology guidelines. It said that cytoreductive nephrectomy with interferon alpha should be used to improve the survival of patients with good performance status. So we'll go through those questions and see what is the current data in the target therapy area. First of all, regarding the incidence, we can see that right now about 1/3 of a patient, comparing to data from up to 2004, will have a nephrectomy. The younger you are, if you are male or compared to female, white patient, and the year of diagnosis definitely show higher percentage of using of cytoreductive nephrectomy. If we look at medical therapy, we can see that most of the patients had nephrectomy, meaning that actually that phenomenon is used very, very often. Now, if we look at despite the fact that we have a higher risk category, in the paper of Heng et al., we see that 2/3 of the population had intermediate risk category. And all of the patients received therapy. Patient selection, it might be a better surgery, it might be a better medication, or all of the above. Now, if we look at that graph, it seems very clear that what we should do is using cytoreductive nephrectomy. But since we have a very high percentage of bias, we can see that the two groups does not match regarding the prognostic factor, the lab result that we know that are associated with survival, and regarding the metastatic site. So if we take that into consideration, we basically cannot say for sure that right now we have a clear data regarding the use of nephrectomy, cytoreductive nephrectomy. Regarding metastasectomy, we can say for sure that if we can perform metastasectomy and remove all tumor sites, we are getting a much better survival, and with complete metastasectomy, we can reach almost 50% of 5-year survival. If it is only lung, we can reach 74%, and that's compared to 14% where no surgery of metastasis site was used. In a different paper, the higher percentage of tumor volume that was removed was associated with better survival. So despite that very convincing data, we definitely can say that all those retrospective papers are biased, and since then we need to focus on two future coming prospective trials. One is the first one is the Carmina that will randomize patient to monotherapy by sunitinib, followed by, and the other hand is nephrectomy with medical therapy. It started recruiting in 2009 and will finish in 2015. Okay, in 2015. And hopefully we'll find from that trial the answer whether cytoreductive nephrectomy is needed at the area of target therapy. And the other one is the short-time paper that randomized patient to medical therapy followed by cytoreductive nephrectomy compared to the other possibilities. And that will help us to understand whether we need so-called neoadjuvant therapy or adjuvant therapy in that scenario. Right now we are facing a question that we use our clinical judgment to solve, but not very clear medical answer. So we use risk category, we use the tumor variables, the surgical risk of the patient in order to choose the patient that will have cytoreductive nephrectomy. What we need to do in addition is to recruit patients to those clinical trial and to use our best clinical judgment to answer the question who of the patient with metastatic disease will need a nephrectomy or not. Currently what's happening with that recommendation is that target therapy replaced the interferon alpha, and most of the centers are using cytoreductive nephrectomy for good and intermediate risk patient, and then followed by target therapy. So in conclusion, we can say that there is an increased rate of the use of cytoreductive nephrectomy. It is, according to retrospective analysis, associated with prolonged survival, disease-specific survival. The two future trials, the Carmina and the short term, will hopefully answer that question. But despite their answer, I must emphasize that they are using clear cell RCC pathology, good risk patient mainly, and sunitinib. So we have many other questions to answer that those two clinical trials will not perform. Thank you very much.
Questions?
Hi, thank you very much for your presentation. We presented in ASCO GU in a paper that was submitted for publication the data that contradicts your first conclusion. We focused on patients that participated in clinical trials with TKI until 2007, And we chose 2007 because that's the time when the Mozart paper on sunitinib was published in New England Journal of Medicine. So we looked at the rate of cytoreductive nephrectomy in TKI clinical trials until 2007 and from 2007 until 2013. And what we found is a statistically decrease in the incidence of cytoreductive nephrectomy. It went down from about 93% to about 83%. And we found also that there is statistically increase in the incidence of poor prognostic characteristics based on Mozart criteria. So our interpretation of the data is that as the medical community becomes more familiar and feel more confidence with TKI, and until the Carmina trial will be mature, the tendency, at least in investigators that deal with renal cell cancer, in patients that you are assumed are fit for cytoreductive nephrectomy, that the tendency is to lower the incidence of cytoreductive nephrectomy.
Okay, so 2 comments about what you said. First of all, 83% is a high percentage, even when you compare to the SEER data that reach 30%. So to move from 90% to 80%, they're both high rate. Secondly, definitely some of the patients that we use to operate might not be good candidate, but actually the data does not support that notion. And when you look at, obviously it is very biased, but when you compare trial to trial of TKI only compared to TKI plus surgery, you have a very big difference. It might be biased, but that's the data right now.
Thank you, Dr. Dotan. I think we should wait for Carmino and ERTC. Thank you again. Okay, our next speaker, just will try to stay with the program, is Dr. Zlotta. And since his topic is in the role of surgery for metastatic cancer, he will focus on the role of surgery in this setting for bladder.
Good afternoon, Gennady, Zohar. I could probably summarize the role of surgery in metastatic bladder cancer in one slide, which is we don't know. So rather than saying we don't know, I'm going to try to walk you through some data that we have and maybe some future studies that we could all think of. I think we all know that some patients do respond to chemotherapy, and we all agree, especially that muscle-invasive bladder cancer is a disease associated with a lot of micrometastatic disease or metastatic disease that we can pinpoint at the present time. But the problem is that we don't know who will be the responders to chemotherapy. And it's possible actually that if people don't even respond, we might be slightly compromising their outcomes. Now, what we do know, and maybe this is valid when we think about the place of a cystectomy in metastatic disease, is that there is very clearly a correlation between a pathological complete response with survival after neoadjuvant chemotherapy. And in that paper recently published in European Urology, they included 13 trials for close to 1,000 patients analyzed. The pathological complete response rate was actually 28.6%. So in patients who achieved this pathological complete response in the primary and in the lymph node, as these patients were submitted to both radical and lymph node dissection, the overall survival and the RR was 0.45, which certainly is something which is pretty interesting and would tell you that if you do respond, for sure, there is a place probably for consolidation. In the previous session, I was saying that more and more at our multidisciplinary bladder cancer clinic in Toronto, we start with neoadjuvant chemotherapy, even with patients where there is some obvious metastatic disease or minimal, and we now look at the response rate and then the way we consolidate. Sometimes we consolidate with surgery, sometimes we consolidate with radiation therapy. Now, I won't spend too much time about neoadjuvant chemotherapy, but one thing is clear, is that despite zillions of studies and studies and studies, very few people actually really do it. And I'm sure that that's going to be the same here in Israel. Even in very academic centers, only 13%. So all this debate is kind of obsolete, and it's possible that because we are not able to identify those responders, that's why many people are reluctant, not to mention the kidney function and the rest. How can we predict? There are some fancy studies like this, looking at microarrays, published in Lancet Oncology. There was a collaborative group with Dan Teodorescu and Yves Fredet. Again, the area under the curve is okay, but nothing really striking, and where you would say, I'm going to change my practice simply based on that. I think many of you are also familiar with the Coxon model, which is an in vitro model where you can kind of predict the sensitivity of tumors to chemotherapy. But again, although the studies have shown nice differences in overall survival, when you really look at the area under the curve, even in that paper, it's not absolutely great. And I'm sure, is anybody here using the Coxon model? No. So that's actually the answer. No one is using it. So we still, like Peter Black here in the audience, say we just pray and we hope that it's going to work. We are using more and more cutting-edge technology, and I personally think this is going to be the future, whether it's pure genomics, it's a combination of genomics and transcriptomics. We clearly need to go into the era of personalized medicine, and that maybe will translate into selecting those patients, and maybe selecting those patients will have a combination of chemotherapy and cystectomy. Now, just to show you how important the role of chemotherapy, and these slides were kindly given to me by Neil, the data and results of the adjuvant trial presented by Cora, where it's a study that never accrued its target accrual, but where the study's results have been published. The gist is, let's look at chemotherapy adjuvantly, and let's look whether you give it immediately or you give it deferred at relapse. And here are the patient's characteristics, with a vast majority of locally advanced cancer, which by definition would be associated with high risk of metastatic disease, and also 70%, as you see here, of node-positive disease. So again, it just answers somehow the question of the role of cystectomy. And at 7 years, there was very clearly a significant improvement in progression-free survival with our hazard ratios, even with such small number of patients of 0.52 and a p-value that was very significant. And if you look in terms of overall survival, the reduction was non-significant, but still the hazard ratios were an interesting 0.78, p-value 0.13, again, low number of patients not achieving the accrual. But it shows you, however, that if you go and address this micrometastatic disease up front, it's better than to wait until people. So the conclusion was very clearly that immediate adjuvant chemotherapy provided a benefit. Now, what is, just to finish, the place of cystectomy in metastatic disease after chemotherapy? There are two trials, small trials published. One is a German series where lymph node dissection and cystectomy was performed in metastatic disease in patients who had a complete response after chemotherapy, a little bit with the same paradigm as Metastatic Cancer. Again, non-randomized, interesting data, but I don't think you can draw any conclusion from that trial. And there are two trials or series, one Italian, one English, with all the caveats of retrospective, where people who haven't been operated with a cystectomy compared to kind of palliative care in metastatic disease had a worse survival. Again, I personally don't think that one can draw any conclusion. I rather would say that the combination of cystectomy, aggressive chemotherapy, whether before or after, is kind of proof that in the selected patients, as long as we can pinpoint who they are, probably the full combo would be helpful. So the conclusion is that the place of cystectomy is clearly far from established, and I don't think that that should be done outside of either studies or protocol. The current trend is sometimes to give neoadjuvant chemo and then consolidate depending on the response. And there is place of very selected cases of surgical removal of nodal metastatic disease, but I really don't think we know exactly who they are. And clearly, this topic deserves scrutiny and further trial. The jury is completely out.
I would like to ask, well, it's like in other fields in oncology. If you have a good disease, you have good outcome. If you have a bad disease, you have bad outcome. So once you have a non-metastatic bladder cancer and a high-risk cancer, and once you give a neoadjuvant chemo, and you want to consolidate, okay, so if the tumor responds to the neoadjuvant, you consolidate, either by surgery or by radiotherapy. But if the tumor does not respond, whatever you will do will have a bad outcome. So would you go then for surgery, or would you go then for radiotherapy?
I personally completely agree with you in the sense that, and this might not be shared by everyone, but I have still to see patients with truly grossly macroscopic lymph nodes where there's no response and where the surgery and lymph node dissection saves the patient. It's going to improve some quality of life. Their local issues will be better, but I still have to see a patient truly surviving. So I think we have different issues here. Are patients with minimal microscopic or high risk where aggressive chemotherapy might early on, as Cora data, for instance, may actually achieve something, or those who had complete response. But if you don't respond and you still have a very big lymph node burden, I'm still very, I question that we really save them.
Even that German study of 44 patients in that very study of cystectomy or metastatectomy in the setting of a metastatic TCC. This was 18 centers over 22 years. So we actually calculated it. It was like one center every 3 or 4 years finds a selected patient where a cystectomy with a metastasectomy is performed for metastatic RCC. So, but we do have a phase 2, phase 3, and at the NCI where there are always open trials. So I encourage strongly to consider those who are failing the primary chemo regimen to be enrolled in those trials. Thank you, Alex.
Next speaker is Neil Fleshner, local control of prostate cancer and high-risk cancer.
So good afternoon, everybody, and again, thank you for the invite to be here. That's wonderful. So I'm going to talk a little bit about the role of surgery in metastatic disease. I'm not going to focus so much on palliative cystoprostatectomy, for example, in locally advanced and metastatic, but I'm going to put a bit of a hypothesis forward and show some data that I suggest at least makes this an interesting topic. So the rationale for doing surgery in patients with metastatic disease in the context of prostate cancer, I'll make 3 points. One is that survival is long, and probably longer than many of you understand, in patients with metastatic prostate cancer. The second is some tantalizing, albeit somewhat weak, data that survival may be improved if the primary tumor is removed. And I'd also make the case that actually removing a prostate with radical prostatectomy in the setting of metastatic disease has very minimal downside. So there are some seminal trials that I think tell us a little bit about the natural history. This is the Messing study reported in the New England Journal of Medicine some years ago, and I think one of the major points here is that even if we look at the patients who got delayed hormonal therapy and we look at overall survival, you can see that the median survival rate had not even been reached, in this case, by about 10 years. And why that's relevant is it tells us that certainly in node-positive disease, the natural history of the disease is quite protracted. Now, you may say that patients in the Messing study had micrometastatic disease. It was a radical prostatectomy study. A recent review conducted by the Harvard group looked at even in patients with bulky nodal disease, the median survival is now over 10 years. In fact, 60% of patients are alive 10 years later, even with bulky nodal disease. And this will continue to improve. We're getting better systemic therapy. I could think of the recent charted data that was presented at ASCO. I'll show a slide from that in a second. And these data don't even incorporate the novel androgen axis inhibitor. So I think as we get better agents towards the end of life, the survival, even in bulky metastatic nodal disease, will be even longer. Now, what about bone mets? Well, I think it's very interesting to think about bone mets. These are the results of the charted study. And what they did is they split up patients to high and low volume disease. You were considered high volume if you had visceral or if you had 4 mets or more. So it's these oligomets patients with 3 sites or less in prostate cancer that particularly have a protracted survival. So again, I'll take you over here to the right panel. If you look at patients treated with hormone therapy alone, so not even with docetaxel, you can see here that we're out at about 60 months. Again, the median has not even been reached. And there's a suggestion of flattening of that curve. So patients with oligometastatic bone disease also have quite significant survivals. They're not the typical patients that you see prevent with super scans 10, 20 lesions. If they have 1, 2, or 3 lesions, their survival is long. So if their survival is long, maybe we can derive some further benefit by removing the primary tumor. Well, what's the evidence for that? Classic axioms in oncology are that removing or ablating a primary tumor is futile once the tumor is spread, and that it only should be done for palliative reasons. However, in some cancers, this is not true. We just saw the data in renal, where we have 2 randomized trials showing improved survival, and certainly in ovarian cancer, where aggressive surgical debulking, even of metastatic sites, has been shown to improve survival. Well, what about prostate? Well, I think this is a bit of a philosophical topic and a bit of a philosophical talk. One question is, what is the source of mets themselves? So clearly, mets are derived from the primary tumor, but are additional mets derived from the primary tumor itself, or are they actually derived from the other metastatic sites? And certainly there are animal models and tumor model systems that would suggest that both can be happening. We're also starting to learn more and more about signaling between primary cancer sites and metastatic sites. The identification of microparticles and exosomes seem to have an important role in regulating metastatic tumor site behavior. And there's good examples of this and bad examples of this. We're all familiar with the classic abscopal effect or accelerated repopulation that can occur from a tumor biology point of view. But there could also be some good that comes out of this as well. Now, there are emerging observations from preclinical models and non-randomized data that suggest this may actually be happening in prostate cancer. So I'll share them with you. They are a little weak, but bear with me. First, let's talk about the disseminated tumor cells. This is a bone marrow aspirate where you can see evidence of metastatic cancer inside the bone. Now, this is a very interesting paper published in JCO about 5 years ago by Weckerman and colleagues. And what they did here is they looked at their experience with bone marrow aspirates. So they did a large number of bone marrow aspirates on a variety of patients with prostate cancer. There was 384 patients. Some had them done pre-op, some had them done post-op. Sometimes they did it both times in the same patients. So I'll show you the data, but basically what it showed, they had 244 patients that had bone marrow aspirates done preoperatively, and 214 had it done postoperatively. That's a typo. So here's what the conclusion is. If you had a positive aspirate for DTCs preoperatively, you were more likely to develop clinical metastases than someone who had a negative aspirate. Makes sense. Patients have already disseminated diseases in their bones. They're therefore more likely to have it than someone who has a negative aspirate. But interestingly, when they looked at patients who had positive aspirates post-op, the prostate is now out of the body, the likelihood of developing metastasis was the same whether the patient had a positive or a negative aspirate. So you could think of a variety of reasons why this may occur, but the inference here is that the intact primary tumor may be signaling or the DTCs to somehow or suppress them in terms of colonization and growth. Interesting observation. There could be obviously other explanations. I think there's also, again, indirect, albeit some weak evidence, if we look at the results of the NCIC MRC PR3 study, which was a Toronto and Canadian-led trial, where patients with locally advanced and high-risk tumors were randomized between ADT versus ADT plus radiation therapy. And in that study, there was significantly better overall survival among patients who got radiation. Now, there's two interpretations of these data, but one is that there certainly are a large subset of these patients who had micrometastatic disease. And why is it, though, that radiating the prostate would improve survival in those patients? Could this benefit be due to this? It's certainly a tantalizing possibility. And lastly, there are some SEER data on this. Again, obviously selected data. This was just published this year in Cancer Epidemiology, where they took the SEER database among patients diagnosed with metastatic disease de novo. There were 7,800 eligible cases in that data set, and a small number, albeit about 450, underwent either a brachytherapy or a radical prostatectomy, and overall survival was significantly better among those patients who had local therapy. Now, again, this may just be selecting out the ligomets type patients, and it has nothing to do with the impact of the therapy, but this is the best we got. So what about randomized trials? I'm glad to tell you there actually are some trials in progress. There's a Dutch trial of 426 patients comparing hormone therapy plus radiation versus hormone therapy alone in M-positive de novo disease. And also there's the Stampede study led by Chris Parker with 1,250 patients with M-positive disease looking at the same treatment regimens, and they're about halfway through their accrual. Unfortunately, there's not much happening in the surgical space. We have a proposal in now as a phase 2 study looking at patients with either node positive or oligometastatic disease. This would have to be 5 sites or less on bone scan, and patients would be treated preoperatively with hormone therapy and cabazitaxel, and we would also then perform radical prostatectomy and node resection in node positive patients and SBRT to the bone sites themselves if they have bone mets. So this is a proposal right now. We hope to start this study probably in the next 6 to 12 months, and perhaps this is the start of having a surgical arm at least, or at least a surgical hand in this space. And lastly, I'll make the case that the downside of doing radical prostatectomy in these patients is minimal. There's no excess risk of erectile dysfunction. They're all going to be on hormones pretty much for life anyways, so they're going to have ED. So really all we're talking about is the small risks of urinary incontinence, which in today's modern technique is quite rare. This is a routine practice with very low perioperative mortality rate. So I'll just conclude that selected patients with bone mets and those with nodal mets have very long natural histories. There's some interesting observational data that suggests perhaps that some primary therapy to the tumor could have benefit. I think the radiation oncologists are ahead of us on this, but I think that surgery is also deserving of trials, especially in patients with low volume oligometastatic disease. Thank you very much.